So what we are going to do is we're going to present in a virtual format. If you are at Carr Auditorium, you are welcome to come here and listen to the presentation, but you would have to project your own slides. So this may be better today attended virtually. We are going to welcome Dr. Susa Coffey and Dr. Jorge Salazar. We are very privileged to have them here with us today. Dr. Coffey is a professor in the Division of HIV, Infectious Disease, and Global Medicine at San Francisco General, and the clinical lead of the RAPID program at Ward 86. Dr. Coffey is a fantastic HIV clinician educator and a leader in RAPID ART and now RAPID Restart implementation. Dr. Salazar is an infectious disease fellow in our division. Dr. Salazar is an HIV provider at Ward 86, and his research focuses on RAPID Restart implementation. We are truly honored to have them share insights on RAPID starts and restarts. Please warmly welcome Dr. Coffey and Dr. Salazar. Thank you so much.
Thank you, Liz, for that great introduction. We are going to present some cases today from RAPID and RAPID Restart. We have no disclosures, and here are our objectives. And you can read through them, but our main point is to tell you about some patient cases that we think illustrate some aspects of HIV and HIV care, including strengths and challenges in our systems of care. So launching with a few definitions. RAPID will refer to persons with new HIV diagnoses and to starting ART as quickly as possible and ideally the same day as diagnosis. RAPID Restart will be applied to persons who are off ART and often out of care. And we're restarting ART as quickly as possible on the day of their presentation to clinic. Both are formal practices at Ward 86, RAPID in place since 2013, RAPID Restart since about 2020, and they are usually done through Ward 86 urgent care, so the drop-in clinic. And I'll point out that in this current day of HIV in San Francisco, where the number of new diagnoses is in general going down, the number of RAPID restarts, or the number of people churning on and off of ART, and the need for RAPID Restart is much higher than the need for initial RAPID starts. So I'm going to present a RAPID case. Jorge, Dr. Salazar will present two RAPID Restart cases. This one is not a mystery. It's about acute HIV. And I want to remind you all of some aspects of acute HIV, because this is something rarely seen unless you work in acute care, but we see 2 or 3 cases every year, occasionally more. And it's hard to diagnose unless you're thinking about it. So this is a 48-year-old cis man who presents to the emergency room with 2 to 3 days of fevers, productive cough, body aches, generalized weakness. His temperature is 38.9. His other vital signs and his exam are pretty non-revealing. His chest x-ray is normal. His COVID test is negative. He has a basic lab workout up that's okay, unless maybe you scrutinize the absolute lymphocyte count, which is on the low side. History, which could have been available, which was available to the clinicians at the time, I'm not sure how much they paid attention to it, was that he's a daily, he injects meth daily. He has sex with women and men. He was formerly unhoused for a number of years and then placed in an SRO, long-term housing, during the pandemic. He'd had multiple ER and urgent care visits over the previous years, but absolutely no primary care. Last summer, he presented to adult urgent care with Mpox. He returned there again with even more pain, and then to an outside ER with even more pain, and received no treatment other than NSAIDs. He also last fall was hospitalized briefly with Shigella. This was at this time from the inpatient service. He had his one and only HIV test in 5 years of appearing to healthcare sites in San Francisco. It was negative. And he also had rectal CT chlamydia last year. So themes that I take away from this brief tour of his history is that he's at very high risk for HIV, and he has a lot of touch points with the healthcare system, but there are many missed opportunities for prevention. He has no continuity care, and yet he's pretty persistent in seeking care and going back again and again if he doesn't get the care for his acute issues. So moving forward with the ER, they thought he likely had a viral URI. And the note says they considered HIV. They knew that he had been negative 6 months ago. They also considered a variety of heart and lung conditions, but said that all of these were less likely given his history and presentation. And you got to kind of wonder about that, being less likely. They did not do an HIV test at that time. They did oddly order chlamydia and gonorrhea, STI tests, without an HIV test. Unclear to me why this was done. This chart is just to remind you that symptoms of acute HIV are very varied and very non-specific. So you have to be thinking about it to think about it. Fever, fatigue, malaise are very, very common. We'll see in a second that this develops some oral manifestations. Those also are present in about 40% of people. As we go forward, I'm going to give you a few little takeaways about acute HIV. This is my first, and that is that if you're thinking viral infection, especially in an acute care setting, think about HIV and check HIV along with your flu and COVID and strep throat and whatever else you're thinking about. And in my pretty strong opinion from seeing a lot of this, it's really important, unless you absolutely know current HIV status of someone, that if you're doing an STI evaluation, please also check the HIV at the same time. So returning to the case, and this is the sequence of events after his ER visit. He's discharged from the ER. 5 days later, he drops into a community clinic. He's still sick. He's quite sick. And now he has new oral lesions. He describes them as blisters. They're actually ulcers. The outside clinic diagnoses him with URI/flu symptoms plus oral lesions. They give some thought to the oral lesions, which they think might be aphthous versus HSV, syphilis, HIV. Fortunately, they send STI labs, and they do send HIV antigen antibody. 3 days later, because of course this is a holiday weekend, his tests come back, and his HIV antigen antibody is positive. His differentiation antibody test is negative. So I was going to ask the audience here what the two main interpretations of this set of serodiscordant, we call it, serologic tests is, and I'll just tell you that they are false positive antigen antibody test, which is not uncommon in a healthy screening population, or acute HIV. And remember, this is a testing situation. It's not a screening situation. So likelihood of acute HIV will be very high here. The provider, I think, was a little flummoxed by the results and wrote that they were inconclusive and needed to be repeated. Fortunately, they included an HIV RNA on the repeat lab checks, and that is the correct thing to do. So 2 days later, the patient comes back to the clinic, has labs drawn. Again, the same configuration of serologic tests, serodiscordant, but the viral load is greater than 10 million. So nailing the diagnosis of acute HIV. So why this configuration of lab tests? And it has to do with the sequential emergence of the different blood markers of HIV infection after the time of exposure. So you all remember this graphic from your training, but HIV RNA goes up first and is detectable by the lab after a week, 10 days, 2 weeks, something like that, followed by P24 antigen, and then followed later by anti-HIV, IgM, and IgG antibodies. And so we're catching this person presumably where the initial test, the screening test, catches P24 antigen, but the antibody differentiation test is still negative. So he's in the window period. So what happens next, 1 day later, is that he's called back to clinic and he started on ART. The regimen they choose is darunavir, cobicistat, TAF, FTC. It's a solid regimen for rapid ART start when you don't have a genotype. I'm not exactly sure why they chose this one, but it's a solid thing to start. He's told to come back in 1 to 2 weeks, but he does not have a follow-up appointment, and he does not have, in his mind anyway, a solid follow-up plan. So my takeaways here are, if you're about acute HIV, or if you're even contemplating the possibility of acute HIV, order the HIV RNA right up front. You can see that while this, from the point of view of the primary care clinic, might be a relatively quick transit from diagnosis to treatment, the days are adding up here, from the ER visit to the initial clinic visit to the test to the retest and finally starting. This is much slower than we would want, especially for a person with acute HIV. He could have been tested and treated back here or here at any time point earlier in this trajectory. Second point is, if you see serodiscordant results, think immediately about, could this be acute HIV, and act quickly to try and figure out the answer to that. The FAST team can always help with that if you have questions. So we're going to move forward with this case, and we're going to shift into sort of next stages of care away from acute HIV. And so there's stuff happening in the background here. The links, the DPH wonderful links navigators find him and try to link him to care at Ward 86. There's a couple of issues, of course, with insurance that has to be assigned to CHN clinics, and he needs a refill of his ARVs, and there's some communication issues that have to be smoothed out. But finally, 5 weeks later, Links puts him in a lift and sends him over to Ward 86, where he engages with our wonderful rapid team, our rapid support team, comprising of case managers, social worker, and RNs. Then I meet with him as the clinician, and he says that he began feeling much, much better as soon as he started ARVs. He has not missed any doses of his ART. Sorry, he has missed only 2 doses of his ART. He does not have any side effects, but he says right up front, he's not sure how long he can take the pills, and he asks about injectables, which he's heard about. We have a brief discussion about this. His baseline genotype shows no significant mutations. We talk about his meth use. He has no interest currently in cessation or reduction, and we draw his follow-up labs. We see him 2 weeks later. His viral load is about 4,000 after 6 weeks on ART. It's a little hard to judge if this is an appropriate drop given how high his initial viral load was and the fact that he's on a protease inhibitor, not an integrase. But he acknowledges missing some ARV doses. In fact, he looks at this number on the screen and he says, oh, I need to take more of my HIV meds, don't I? So signal for me. He again asks about long-acting injectables, and we discuss this, and we discuss what we would need to see for a sort of medium-term switch to long-acting injectables. 3 or 4 weeks later, we see him again. His viral load at this point is just shy of 800 after 11 weeks on ART. I don't need to say it to him that I'm concerned about this sort of piddly drop in viral load. He tells me he's missing a lot of doses, maybe missing more than he's taking, and doesn't think he can take PO meds anymore. So my question for you all is, what would you do at this point? Would you continue current ART? Would you switch to bictegravir, TAF, FTC? Would you switch to long-acting cabotegravir, rilpivirine? Would you do something else? And Joe, do I go forward? I go forward. Okay. And is there a way to tell? 100%, but I don't know if that's 100% of one person or 100% of 95 people. But let me tell you, I can understand that you would want to continue a really bulky protease inhibitor-based regimen. Ooh, somebody wants to switch to long-acting. Bold. Should we wait one more second? And here's what I elected to do, which was to switch him to long-acting. My rationale was he was telling me he wasn't taking his oral ARVs. There was no way his viral load was going to go any lower than it had. It had plateaued at 800, likely. So I did an expedited referral to our close collaborators, the Ward 86 long-acting injectable program run by our clinic pharmacist led by Janet Grashowski. We work really closely with them, especially about these sort of expedited referrals. And they provide support and additional education about long-acting, double check the criteria for injectables, et cetera. So he got his first injection of cabotegravir rilpivirine 5 days later. His HIV RNA was less than 34 weeks after the first injection. He's now had 2 injections. He's coming up to the 3rd. He's tolerating. He's very happy to be off oral ART. Plan is to continue to follow him monthly with monthly injections and primary care visits and interim rapid team visits for the near future. The rapid team is really involved with him, doing check-ins, practical supports, food, rental assistance, reminders, etc. The patient is really appreciative and seems engaged with our team. So I'm going to wrap up now and remind you that delays in diagnosis with acute HIV are very common. Patients can be very sick and for a long time. Serologic tests can be discordant or even negative, so check the HIV RNA and treat immediately if AHI is suspected. Early ART helps decrease symptoms very quickly and can limit the viral reservoir. And then I don't have a time to talk about the first issue here, but Ward 86 New Directions, we're really interested in exploring the switch to long-acting injectables for selected, and I'll emphasize selected patients in both the Rapid and Rapid Restart programs. And you'll hear more from Dr. Salazar. Thank you.
Thank you so much, Susa, for that wonderful case. So I have two cases I want to share with you all today. But before I get into them, I just want to go back to this question: what is rapid restart? And the way that I've sort of been thinking about this and conceptualizing this in my mind. And so basically, this is clinician prescribed ART to someone with a known diagnosis of HIV who would otherwise have unreliable and inconsistent access to ART and is re-engaging into care. And there are very broad scenarios, but each of these have their own unique flavors and nuances. And the way I've sort of just simplified this is people who are new to Ward 86. So this encompasses people who may have had HIV care locally within San Francisco, for example, the Kaiser system or Sutter, and they have some problems with insurance and are now coming to Ward 86. And then the other group is someone who's known to Ward 86 before, but they've also been out of care for some time. And this time frame varies a lot. It could be over 3 years, 1 year, 6 months, et cetera. And then there's a clinic coordinated action to address barriers of disengagement that they had and some sort of response to promote their retention and engagement moving forward. And I'll emphasize that there isn't an intervention per se that we've sort of hashed out, but this is sort of a response is needed in this situation. So moving to our case, this is a 22-year-old Latino MSM. He's seen in adult urgent care for an STI evaluation and then referred to Ward 86 with a fast and rapid team after he has a screening test that's positive. So he has a social work intake and then sees a rapid clinician at the same day. And so in his visit, he says that he's had a subacute rash for about 7 days and then has also had 3 days of chills and malaise followed by a development of a painful rectal lesion. And he has reported recent condom-less receptive anal sex. His vitals are normal, and his labs at the time that were obtained at urgent care showed normal chemistries and CBC, and he has a positive RPR with a titer of 1 to 64. So at his rapid visit, some more history is obtained, and he's noted to have a prior episode of perianal HSV. He's not currently on any medications or valacyclovir, and he last had an HIV negative test in 2017. For his social history, he was born in Mexico. He'd been living in San Francisco for the past 10 years. And he's actually working as a restaurant manager, and he's also in school at a local college. He's living with his family, and he reports no severe substance use disorders. He has occasional vaping and alcohol use. And he has no report of any mental history that's documented anywhere in his chart. So to wrap up his rapid visit, he started on Big TAF FTC and follows the clinic protocol here, which is he gets a first dose of his ART in clinic. He's given a starter pack, and then he receives a 30-day prescription to his pharmacy with a couple of refills. He also receives treatment for presumed secondary syphilis. And for his painful rectal lesion, there is some testing that is pending, but he received some supportive care and some analgesics for that. So his labs have now come back. His CD4 is in the 500s. His viral load is 24,000. He's also diagnosed with Mpox from his rectal swab. In the following days, he does have worsening rectal pain, and he comes back to Ward 86 urgent care. He's also started on BID tecovirimat. And then The next slides sort of show his follow-up in care, which is he's had minimal engagement and patient contact. He's had 3 scheduled PCP appointments, but he has not attended any of those. And this is over the following 3 months. So at this point, this is going into all of fall and early winter. And in the chart, there's obvious extensive outreach attempts from the social work team and FAST team. And this goes on for months and months. Eventually, he has a links navigation case that is opened almost a year later after his rapid visit. They do some intensive navigation services. They're able to contact him, and then he's willing to come back to Ward 86. So now he's at his rapid restart visit. He reports that he only took ART for about 2 months. He had gone to Mexico for some unknown duration of time, but this is what he reports. At this moment, he's feeling well. He has no acute symptoms. He does say that his family is unaware of his HIV status. And for his vitals, they're unremarkable, and he has some thrush noted on his exam, and then he's restarted on Big TAF FTC. His labs return now with quite advanced HIV from his initial CD4 down to 180 now, and a viral load is over 1.6 million. And to date, he has not returned to clinic despite more outreach from the FAST team and social work team. So this case sort of reflects this article and study that I saw, and I wanted to bring up and discuss. But this sort of looks at the role of case management from this HIV Prevention Trials Network study, where they really recruited people who were quote unquote out of care and hard to reach. These were people who were recruited through respondent-driven sampling and direct recruitment methods, who had unsuppressed HIV, and they were from 4 sites listed here. And really what this study was wanting to see is whether case management services had any impact on viral suppression, defined as a viral load less than 200, 12 months after linkage to care. And so to comment further on this intervention, they randomized participants to enhanced case management 1-to-1 to standard of care. Standard of care just met the clinic protocol, their usual clinic protocol for linkage and retention. And enhanced case management was done through a full-time case manager who was trained in HIV care, but was also trained on motivational interviewing. And they also included extensive communication services via text messaging, text messages to support the patient and whatever was going on in their life, reminders to attend clinic, and so on. They screened about 1,300 people in total, and about 900 of those were found to be living with HIV. And for this assessment, they included the people that was, again, quote unquote, hard to reach or out of care, meaning they were not suppressed from HIV. And so this was 144 people, followed for 12 months. And at the study visit end, they found no significant difference in viral suppression between the case management group and the standard of care arm. And so here I thought this was quite interesting. The authors thought there might have not been distinct differences between the enhanced case management versus the standard of care linkage and retention, or there just wasn't enough support for this hard to reach population. But pretty remarkable that there was no difference in viral suppression for this group. For the case takeaways here, for this particular case, there was challenging engagement upon entry and reentry to care. It was kind of a head scratcher because you would think of the usual barriers. They were lacking in this case. He was housed, he was employed, he was in school, he had a good background knowledge on HIV, good understanding of his health. There was no substance use disorder or severe mental health illness. So it was remarkable that he was not engaging in care. Made you wonder if there was stigma involved that drove his poor engagement or some other factor. And then it just highlights that there can be such extensive social work support and navigation services, which can help to bring people in, but it may not be enough in and of itself to help people achieve viral suppression. So moving on to case number 3, this is a 33-year-old man with HIV, bipolar disorder, and meth use. And he's presenting to re-engage in HIV care. You see that he's been out of care for over 3 years. He was last Ward 86 patient in 2019. And these labs in EPIC from 2020 showed a CD4 in the 700s and a viral load that was undetectable. These labs were not in the Ward 86 care system. So he comes in for a rapid restart visit, and he's reporting worsening auditory hallucinations and anxiety for several months. He does in the background have active methamphetamine use, which is almost on a daily basis. And he reports that he's living in his deceased father's home, who his father had passed away last year, and his home was on probate. But he did say that there was very unsanitary and poor living conditions there. For his HIV history, he was diagnosed in 2012. His risk factor was injection drug use and MSM. He had a history of oral candidiasis. And for his ART history, he was initially started on boosted enanzanavir TDF FTC in 2012. At some point in the mid 2010s, maybe 2015, he was switched to Triumec. And this was thought to be due to possibly renal effects from TDF, but it wasn't totally clear from his chart. And he had viral suppression on this regimen. It took it until 2020. He had no report of virologic failure to his knowledge, and his baseline resistance testing was without any major resistance. Further history elicited showed extensive past psychiatric illness, ADHD, bipolar disorder, depression, psychotic disorder. He had been on multiple psych medicines in the past with different levels of efficacy. And for his social history, he did not finish high school. He obtained a GED. He had spent some time in jail in his 20s. He was currently living in South Bay in his father's home, as I just mentioned, and currently unemployed, but receiving federal and state disability. And from substances, his main substance use was methamphetamine. So for the ARS question, I'd like to ask you, what ART management would you recommend at this time? Okay. I'm going to highlight what was done. I think there's many different answers here. I'm interested to see that there's a group that is already thinking about long acting. That's interesting. So what was done was he was started on Big TAF FTC. Again, I think there's many different approaches that one could do here. His labs came back. His CD4 was 39. His viral load was 103,000. The rest of his labs were unremarkable, and he had a genotype that was pending. So he had a PCP that was coordinated that was done 2 weeks later. He said he had picked up his Big TAP FTC the prior week, but he'd really only taken 2 pills. He was really struggling to take his medicines, mentioned that he was just forgetting, didn't have a good routine for it. He was also prescribed Septa for PJP prophylaxis, but he preferred to prioritize his ART. And really, he was really interested in getting on psych meds again, getting mental health services. The clinician at this time sort of was talking to our psych team at Ward 86 and also enlisted social work support for his housing issue. So he comes to urgent care not long after his PCP visit. Now he's having really unstable mood, having worsening auditory hallucinations. This is again in the context of daily meth use. So he said he wanted to start psych meds before, and now he's offered IM paliperidone or Invega, and he actually gets this administered in clinic. He's still doing poorly with oral ART, and his genotype results coincidentally have also come back this day, but also noted that this was off while he was off of ART, showing no major mutations and just some minor PI mutations. So again, want to ask, what would you do now in terms of his ART management? And on the right, I just have a brief history of what's happened so far. He's out of care, started on Big TAF, FTC, started on antipsychotic. These are his labs. So would you switch to some Susa? Would you continue Big TAF, FTC, hoping for improvement while he's on psych meds? Really encourage Biktarvy, see if his viral load comes down, and then maybe talk about long acting, or just pull the trigger now and start him on long acting. So at this time, the clinician did D. And so what I mean by expedited referral of long acting, she enlisted the pharmacy team and said, this patient needs to get started on long acting right away. And so this is just the timeline of him entering care from his rapid restart visit. And basically, essentially, within less than a month, he gets his first long acting injection. And at the time of his injection, his viral load has come down to 74. So the follow-up visits for him, he has a 1 month PCP visit, and his CD4 is 70, viral load is 39, still suppressed. He gets another dose of long-acting Cabril, and his antipsychotic, also intramuscular. Now, the next things are kind of interesting for this case. So he does get his other injections for long-acting Cabril, but he actually decides that he needs to transfer his care back to the South Bay. The commute to Ward 86 from where he's currently living is kind of too much, and he thinks he should just go back and receive care locally where he's at. He establishes care with a PCP in the South Bay, and also, he's able to continue on long-acting Cabril and his antipsychotic, despite sort of navigating the logistics of transfer of insurance in clinics. So he's able to continue that. He gets a total of 4 monthly injections of long-acting rilpivirine, but then he decides he actually wants to switch back to oral ART. And this is due to some injection side reaction from the injections. So the case takeaways here was, at the get-go, there was a very thoughtful patient-centered approach involving multiple teams, social work, psych, to address his biggest barriers at reentry to care. The use of long-acting medications here, both antipsychotics and antiretroviral therapy, seemed to allow for a period of stabilization amidst severe barriers in his care. And this case really just highlights that alternative treatment options are needed under different circumstances and different life situations, and also that personalized modifiable care should span all aspects of care to enhance engagement. So now I'm going to go back to rapid restart, and I want to highlight sort of 3 big bullet points of rapid restart. Number 1 is that this is an understudied topic in patient population. I'd previously mentioned some formal reports from Johns Hopkins and Emory that investigated this patient population, really showed that there was lower rates of viral suppression when they compared rapid restart to rapid start. So that's number 1. Number 2 is that this is obviously an urgent unmet need. These are populations with social health inequities and disparities. In the Hopkins and Emory paper, they really showed that the demographics were people identifying as Black race, unhoused, with unemployment and on public insurance. And obviously there's barriers to engagement here and to viral suppression. And then the third is that this patient population is also relevant to local, national, and global HIV targets. And here I'm just referencing the UNAIDS 2025 targets on ensuring that 95% are on ART, and then the third 95% are suppressed on ART as well. And they also call for integrated approaches to care, as well as removing barriers which span gender equality, and so on. So now I want to share some data from Rapid Restart from this year. This is a small cohort from January of this year to September. So far, we've had 61 rapid restarts. 6 of these had restarts previously at Ward 86, and then 7 of these were started on oral ART, but they were then switched to long-acting Cabril. The demographics of these 61 patients are listed here. Somewhat of a busy table, but I'll walk you through. I forgot to include age, which I'll mention. The median age was 37, and the range was somewhere from 23 to 69 years old. Predominantly male, and then as far as race and ethnicity. This was a predominantly white group, followed by Latino and Black. And really, I'll highlight the rest of the stuff with these bullet points, but a majority are unstably housed and homeless. Nearly half have mental health issues, with depression being the most common, and stimulant use is the most common substance use issue. With respect to these two things, mental health and substance use, for this year, we really try to have the clinician decide, or the social worker during their intake, see if these patients identified mental health or substance use illness be a driver of their disengagement. And so these are patients who are saying that, yes, this was really impacting their life in the past 12 months. And lastly, which was really kind of striking, was over 40% had a CD4 less than 200. As far as short-term outcomes in this group, so we looked at number one, PCP visits, at least one that was kept within 3 months from rapid restart, and then again within 3 to 6 months from rapid restart. Number two, attainment of viral suppression within the same time intervals from rapid restart. This was a smaller cohort for which we had 6-month data. So this was from September 22 to February 2023, so an N of 36. I'm going to highlight a few things here. So the first thing is looking at the early engagement period. So within the first 3 months of rapid restart, we see just above half of patients are have at least one PCP visit. Hard to make of this, this doesn't include, or this means that some people could have no visits, but then at a 3-6 month mark, they may be attending that. The next thing I want to highlight here is their viral suppression outcomes within 3 months, and then again 3 to 6 months. So the asterisk just means I included patients who did not have viral load data. So worst case scenario, we assumed if you did not have a viral load measurement at this time, we assumed that they may be disengaged from care or viremic. So a viral suppression rate of 47% within 3 months of rapid restart. And then again, from 3 to 6 months, a viral suppression rate of 38%. This is worst case scenario. If you exclude those people and you include only people who have viral load measurements, the viral suppression rate improves to 71% and then 70%. So I don't think it's as low as the 30s or 40s, but I don't think it's as high as the 70%. I would estimate that our viral suppression rates are somewhere between 50 to 60% based on this. So what's going on next? So there's obviously lots of collaboration within the rapid and fast team, and we want to systematically identify and track rapid restarts and their outcomes. We're looking at predictors of disengagement and loss to follow-up. So really trying to identify at their baseline rapid restart visit, is there a big insurance problem that preceded their disengagement and ART interruption? Are they new to San Francisco? Is there something else that's underlying? Hopefully this will allow us to identify and then implement supports needed for long-term engagement. And then also, as Dr. Coffey mentioned earlier, evaluating the impact of long-acting ART and select rapid starts and restarts, seeing what have been the successes, what have been the challenges, and so on. And then sort of ending near this talk is just an outline of multi-interventions that are relevant to our cases, but also relevant to other cases in our clinic and elsewhere. So there's our local health system, our clinic. We should have integrated HIV care, and this spans all these multidisciplinary teams that we have. Access to ART choices for us, the SPLASH program has been great. From an individual and community level, having the patient have social support, getting engaged with family and friends. We saw that in both of our cases. Patient advocacy, promotion of self-efficacy, and then the much larger public health infrastructure, making sure that there's partnerships involved and surveillance efforts and equitable health HIV policies. But in the middle of all this is patient-centered care. So to conclude, 486 rapid start, and especially the restart patients, have many challenges to continuous engagement in care. We see these in our cases here. Understanding their barriers to care is needed in order to craft targeted supports and interventions. Long-acting ART could be a tool for select individuals. It's definitely not the answer, but it needs to be embedded in a broader range of services and support. And then there's a lot more to come from rapid start and restarts at 486. and look forward to sharing with you in the future. And these are acknowledgements. Also want to acknowledge Jan Oscarson and Mary Shields, and all these individuals involved have been very instrumental for this. Thank you so much.
Thank you so much, Jorge. If everyone could put your questions into the chat, we'll have some time now for questions. Can start with one while we're waiting. So thank you for that talk. It was really excellent, and for the wonderful work you're doing. Thinking about the cases you've seen and the data you've looked at Ward 86, I mean, what are the key barriers? And more importantly, like, what is the team? Like, what is the team of multidisciplinary folks that we need for this?
Mind if I start with that?
Oh, yeah.
And you're talking about rapid restart.
Rapid
Liz.
restart,
Yeah, thank you
rapid
for
restart.
the question. So we're thinking, we haven't done the qualitative inquiry yet to define this, but we think in advance that the big three are the main issues. So housing issues, which just so destabilize people, mental health issues, and substance use. And then, you know, there's lots of individual things as well, but those are probably the big three, and we'll find that out as we go forward. And then our team is the rapid fast team. It is not yet fully built out to support the rapid restarts in a truly robust way. And this is our sort of plan for the next year, is to build out the team more after identifying what supports the patient population needs, and really to try and change these numbers, because the viral suppression rate and the PCP follow-up rates suck, right? I think we can agree on that, and clearly we're not doing enough for them.
Thank you so much. There are a few questions in the chat. So one from Sophie Wong. Have you been able to support providers to give rapid restarts in the community settings? How do you manage fears around resistance, etc.?
I mean, yeah, I have quite limited experience with rapid restart, but I'm actually getting involved with urgent care now, and I have done a couple. But the question was about how to advise community clinicians that are doing this as well in resistance. Yeah, I mean, I think sort of the basics is just try to meet the patient where they're at initially to develop good rapport, and use all your tools that you can to get whatever the HIV history is. And if something sounds sort of questionable, use your best judgment. And you know, in the first case was that Dr. Coffey presented was not a rapid restart case, but you know, they chose boosted darunavir. Say that patient was a rapid restart patient. You know, I think they'll do well on that. And once you get more information, you can tailor the ART therapy. So,
yeah. And I'll just add one thing about the community in San Francisco. I think the high volume clinics, including City Clinic, MXM, Magnet, and no doubt others, are doing a lot of rapid restarts. So there is development and comfort of a lot of development of a lot of expertise and comfort with rapid restarts. We're happy to take calls from anyone who wants to do this or has questions about particular scenarios.
Great, thank you. And Monica Gandhi has a question. I think it's, you know, talking a little bit, I know you're going to learn from your data, but what strategies do you think are going to work, and how can we use sort of our existing team to address this at Ward 86, knowing that we need additional staff?
I'll start with that, Jorge, and feel free to chime in. So my sense is, at a minimum, we need more support from social work and case management services, access to mental health and substance use services, which, as we know, are not instantly available for most of our folks in any kind of robust way. We do have expertise at Ward 86 to provide these. We also hope to use use some positions to arch across multiple sites, so not just for Ward 86. And then we need to track data, to collect and track data to find out how we're doing. So we do, we are hoping, I don't know if it's official, to receive some EHE monies to try and build out our program a bit more, but of course, leveraging existing resources.
Okay, great. Some questions about the case with the rectal lesion. For rectal lesions that you're seeing like this, are you swabbing everyone for Mpox, and have you seen an increase in Mpox cases recently?
Yeah, I mean, I think since the Mpox outbreak last summer, any sort of rectal lesion that you're also getting other STI testing for, gonorrhea, chlamydia, you should also be swabbing for Mpox. The second question, have there been an increase? Anecdotally, it seems like so. I don't know the exact numbers, but I have a close colleague at City Clinic, and he's mentioned lots of cases there, has even sent some referrals for our STOMP trial. So I think there has been an uptick the past couple of months.
Thanks. And Oliver Bacon is saying in the chat, they've seen an uptake in cases at City Clinic of Mpox. Follow-up question from Andy Shear, methamphetamine being a big driver of disengagement in care. What are the possible interventions? Are there entities external to clinics that care sites can be partnering with? Like, what do we do about this as one of the main barriers?
Yeah, it was really striking going through that 2023 cohort and just seeing how prevalent stimulant use was, like 90%. So much so impacting their daily life and function. As far as interventions, I mean, I think we don't have a very good understanding of the best interventions for this problem. We have other colleagues within our clinic who are specializing in addiction medicine. They may be more suitable to talk about more interventions, but I think broadly speaking, it's sort of a biobehavioral approach as well as medications, but I'm not sure if Dr. Coffey has other input on that.
Andy, I'm sure that you have some thoughts behind your question, and we would welcome any kind of alliances and supports around this issue, which is huge.
Okay, another follow-up question from Sophie Wong. Can the East Bay call you to get consults on rapid starts and restarts if they can't reach someone in the East Bay?
Sophie, thanks for that question. I'd be happy for people to call me directly. That would be fine. I think probably the HIV warm line also would be available for those kind of questions. So either way.
Okay, we'll give people a few minutes in case there's any other questions. Thank you for those fantastic talks. I learned so much, and I know the audience did as well. We'll give it a minute. Lots of thank yous in the chat. All right. I think if there's nothing else, we'll end a bit early today. Sorry again for the technical difficulties. Thank you so much to Dr. Coffey and Dr. Salazar. That was a fantastic talk, and we will see you for Grand Rounds next week. Thank you.